Good evening and welcome. Thank you for joining the first in series of our OncLive webinars on ovarian cancer, the state of ovarian cancer, how ovarian cancer is evolving in the COVID-19 pandemic. I'm your moderator, Daria Zangari, Scientific Director for OncLive, and I'm very happy to be with all of you tonight. The mission of this webinar is to provide our listeners with a free-form discussion on the impact of COVID-19 has had on our patients with ovarian cancer. We will cover a list of topics that our panel will go into greater detail on, sharing their insights from the front line. In addition to our expert panel in gynecologic oncology, tonight as a special guest, we have Dr. Laurel Musselwhite coming to us from Atrium Health. She has an extensive background in building clinical and research programs in low and middle income countries, focusing on global epidemics, including HIV and cancers caused by viral infections. She has also worked with some of our nation's leading experts, including Dr. Anthony Fauci. So we're very, very happy that she was able to make time to join us tonight for this talk. As you can see from this slide, we will be discussing a variety of topics, which include testing for infection, the impact on diagnosis and screening for ovarian cancer. Tonight, we'll talk briefly about surgical management and some treatment considerations. However, we just want to keep in mind that we will be going into further detail on some of those topics in the next 3 weeks. So stay tuned for some of those webinars to come. If you are listening to this webinar, we encourage you to submit any questions you have. We will try and answer as many of them as we can during the Q&A portion of this webinar. So joining us tonight, we have a distinguished panel of experts, and I will ask each of them to introduce themselves. So we'll get this started with Dr. Herzog.
Hi, Dr. Tom Herzog. It's a pleasure to be with you tonight. I'm a gynecologic oncologist, and I'm in Cincinnati, Ohio, so greetings from Cincinnati. And the deputy director of the Cancer Center at the University of Cincinnati. And it really is a pleasure to be here. I'm sorry we're talking about something that has been so disruptive to all our lives.
Thanks, Dr. Herzog. Happy to have you. And now on to Dr. Monk.
Yeah, thank you and greetings from Phoenix, Arizona. It's my pleasure to be here. I'm also a gynecologic oncologist. Thank you to the supporters. Thank you to the organizers for having me. I work for US Oncology, but have an academic appointment at Creighton and University of Arizona. And with Tom Herzog are the directors of the GOG Partners. So thank you.
Thank you. And Dr. Brown?
Yes, hi. Thank you so much. I'm really honored to be here. I'm Jubilee Brown. I am also a gynecologic oncologist, professor of gynecologic oncology at Levine Cancer Institute at Atrium Health in Charlotte, North Carolina. I am the interim division director there and also the president of the AAGL, so have been very involved from a surgical standpoint with the direction of COVID-19 in that population.
Thank you. And then Dr. Musselwhite.
Hey, good evening. I'm honored and humbled to be counted in this group. I'm a gastrointestinal medical oncologist. I recently came to Levine Cancer Institute from Duke and am director of outcomes research for the Department of Solid Tumor Oncology at Levine. Very good to be here.
Great. Thank you so much. So now we will turn it to Dr. Monk. He'll just be going over a little bit about SARS-CoV-2 and what COVID-19 is.
Yeah, thank you. You know, maybe if I can start with a story. Yesterday was a very traumatic day for me. As many of you know, Cinco de Mayo is a religious holiday for me. And, it was a virus that had the name of my favorite Cinco de Mayo beer. So I'm recovered today and I'm back on track, but it's really my pleasure to be here. On a more serious note, yesterday was the most deaths that we've had in Arizona. We had 34. Today we had 33. So this virus is here among us. My thesis now is the new norm. The world will be eternally changed. So I'm really grateful to talk about this. I'm just going to present one slide sort of about the lexicon. The virus, as you see here, is called SARS-CoV-2. It is a severe acute respiratory syndrome virus. That's what SARS stands for. And it's the second coronavirus. And so it's SARS-CoV-2. The disease associated with it is called COVID-19, coronavirus disease, because it was originated in 2019. I'd never even heard of Wuhan, China. Tom said, "What do you mean? I was just there 2 months before." So now we'll never forget Wuhan, China. As you know, it's transmitted via droplets and fomites, and we'll hear a little bit from Laura sort of about transmission, and we asked her to be here today because testing really is so important. It is a 30,000 kilobase RNA virus, the positive strand, so it's there all ready to go. It's there ready to hook up with the ribosome and to make protein. So as you know, it enters through the respiratory tract. It has these spikes, hence the name corona, like a crown, and it binds to the angiotensin converting enzyme, which is on the alveoli cells. So it's my pleasure to be here. Thank you, and I'm going to turn it over to Dr. Herzog.
I think we have Dr. Brown going next. Yeah.
All right. Sorry.
So we'll have Dr. Brown just.
Didn't mean to talk over you.
It's those coronas you had yesterday.
I know, right? You have no idea.
Of all things.
I
Maybe
know.
go get a taco.
That's right. I'm honored to be confused with Dr. Herzog any day. So let's talk for just a moment about COVID-19 by the numbers. So unfortunately, we have 3.68 million confirmed cases globally now. This truly is a global pandemic. The U.S. now officially has the most confirmed cases at 1.24 million. And unfortunately, we stand at over 72,000 deaths. As everyone who's watching likely knows, social distancing and stay-at-home measures are still encouraged. You know, this is important not just for our patients, but ourselves, for everyone we know. And we'll talk about really why that is and how we need to continue that process. The issue, though, for some in our population is that folks who have very serious medical conditions that require urgent attention don't really have the option of staying completely isolated. And so we have to consider how we manage those patients within this era, keeping in mind the social distancing that's necessary. You know, as we all know now, COVID just simply impacts everything. And certainly why we're here today is because it includes how we manage ovarian cancer. I mentioned that I've been involved internationally in putting on webinars and working on education within the surgical community. This slide was from, as you see, March the 16th. And in March the 16th, you can see that most cases were in China, and it was really just sort of a smattering elsewhere, ramping up. But take a look at this. Those numbers changed. This was a webinar that I gave a month ago. And at that point, we were at 900,000 cases worldwide and 46,000 deaths. Exactly 1 month later, here we are at 3.7 million cases worldwide and 260,000 deaths. This is just incredibly devastating for the world. One thing that I think is worth mentioning, you know, we talked for a second about social distancing. Let's go back to a month ago. Look at that curve down in the bottom right corner of your slide there. And if you see, that is the definition of an exponential rise. With all the social distancing that we've done, that curve actually has changed. And so, you know, we'll hear more from Dr. Musselwhite in just a few minutes, but to me, that looks like good news. It doesn't change how we manage our patients, and these are friends from around the world who've informed all of us on how we manage our patients. And so we, more than any time in the past, have had to learn from our friends and colleagues internationally. We learned that social distancing matters. We learned that the curve can be flattened. This was the initial presentation that demonstrated that. And this is what happened for us in Charlotte. What you can see is that we were on a path to destruction. You know, that exponential rise happened. And when Charlotte put into place social distancing and really shut down the city, you can see that that curve changed. So how does this impact our medical management of our patients? Well, there are really a number of issues that matter. So we all know about the rapid global speed of onset. That's really been difficult in terms of our management of these patients, knowing how to intervene rapidly. And we've, as I say, had to learn from our partners worldwide and really integrate lots of information very rapidly. 5 to 10% of patients who get COVID-19 have very severe management problems, and this can include intubation, ICU placement, and for many of our cancer patients, which we'll talk about, unfortunately, death. The prevalence of asymptomatic carriers is a real issue because the symptoms arise 2 to 14 days or longer after exposure, and this leads to predominantly asymptomatic spread, so it's hard to avoid COVID if it's in your community. And there's also some symptom overlap with the common cold, influenza, or allergies. And so even though patients do present with fever, cough, fatigue, productive sputum, dyspnea, and myalgia, it's hard to pull out if those symptoms are related to COVID-19 or something else. And one of the hallmark symptoms, the absence of smell and taste, is pretty unreliable in our patients with ovarian cancer who are getting chemotherapy. You just can't use that. And I think the final detail is that there's a lack of experience. We don't have anything to draw upon. This is really a sort of a novel situation. It's a novel coronavirus. So with that, I'll hand this over to Tom.
Jubilee, thank you. And I am so sorry for the confusion because there's no way that I look as good as you. So it's great to be here. So, when we look at the whole issue of, I think, the interlap, if you will, or the interface between COVID-19 and what we see with the virus. I'm going to make sure we got the slides advancing here. There we go. Yeah. So I think the biggest problem that I've actually seen has been limited data sets. So, even if we look back at the first data that came out of Wuhan, and yes, I was there. I think I left Wuhan December 19th. So that certainly brings this really close to home. And I'll tell you about testing when we get into that as well. But as you know, one of the first reports that came out was by Jing Yu, that was reported in the research letter in March 25th, 2020, and they looked at 1,524 cancer patients that were hospitalized and looked at their cancer incidence and so forth. That's really where the first observations came from that said that cancer patients appear to be more susceptible to picking up this virus as well as the death rate. And then we've seen recent data from New York from Montefiore showing the death rate significantly higher in those. And then one of the things that's been interesting that you get into is, who's more affected, which type of cancer, and which type of therapy are they on? And those are all questions that remain out there. The lung cancer data from China, non-small cell lung cancer, is very interesting because they appear to bear the greatest number of deaths with this disease. So that doesn't fly in the face of common sense, certainly, in that you would think that those with lung problems already would be at greater risk. So certainly that makes sense. But we sort of have to normalize that for the data and the incidence of lung cancer across countries and so forth. So we really need bigger data sets. But it is very clear that cancer patients will are more susceptible to getting infected with this virus. And they're at higher risk for having to get admitted to the hospital, for needing ventilation and ICU admission. And as I said, there was just data that came out May 1st from the experience at Albert Einstein that I thought was pretty cogent in terms of looking at what we saw there. They looked at 218 patients with cancer who tested positive for COVID-19. And of those, 61 died. So they had a 28% mortality rate. And this is here, obviously in our country. with what's gone on at the epicenter for our country in New York City. So we certainly know that cancer patients are bearing the greatest brunt of this, and then which subgroups is that, which types of cancers are older cancer patients, and then those that are suppressed perhaps. We know the hospital-acquired transmission is a big part of this, and they found that in the New York experience as well, over 30%, just like the Wuhan experience, over 30% of the patients within 30 days of their contraction or diagnosis of the virus actually had been in either a nursing home or a hospital. So it's very interesting to look at the touch points involved with transmission. So we need bigger data sets, there's no question about it, but we continue, as you know, the journals are prioritizing articles on COVID, and that's very helpful. Per the CDC, patients with cancer and survivors are at higher risk for severe illness, as we've said. This is the Wuhan data here, looking at what you see in terms of the number of cases that actually have cancer compared to the incidence of cancer that you see. So I think very, very, very similar to what I said. These patients, if they're older and if there's comorbidity, they do worse. And that's really been borne out in China, it's been borne out in Italy, and it's been borne out in New York. So these are patients with cancer that may have a higher risk of serious adverse events. So if we look at the, in blue is invasive ventilation or ICU admission or death, plus the clinical indication, and then in the pink is the invasive ventilation or ICU admissions or death based on no cancer, cancer survivors, or patients with active cancer. And as you can see, again, our active cancer patients certainly are doing worse there. If we look at probability of an event, you can see, again, the cancer patients have a much higher incidence of having a fatal event. Case fatality analysis from Italy through St. Patty's Day, 1,625 deaths out of 22,512 cases, so 7.2% mortality, higher than updated case fatality rate from China. I mean, this is always difficult, and we'll probably get into this a little bit with our testing discussion tonight, but when you're looking at case fatality, it always depends, of course, on how many are getting tested. So that's a big part of it. If you look at overall population, those numbers are probably much smaller. Older overall population, closer case fatality rate by age group. Subset of 355 patients with detailed chart review, as you can see here. Older patients, lots of pre-existing conditions, and those with cancer, those were the groups that did worse. So again, do they have a poor prognosis? This is from Mount Sinai, another data set from New York City, looking at 5,688 patients that had COVID-19, and there were 334 with cancer among those. And you can see the breakdown here. And a little bit different than what we saw in the Wuhan experience, in which they had the highest number of cases were non-small cell lung cancer due to the high smoking prevalence that we see in China. You can see here somewhat of a different distribution here in the United States. If we look at those patients, those with cancer were intubated, quite a bit more likely to be intubated, almost twice the chance of being intubated. In this case, the death rate was not significantly different. So a little bit different than what we've seen from some of the other data sets. If you look at age groups, those that were older than 66 or 66 or older, again, they had a higher risk of intubation. Patients with who were younger than 50 had surprisingly a high, very high mortality rate. And that's somewhat different than some of the other databases that we saw in China. So again, while these numbers are somewhat impressive of thousands in the denominator, when you get into the numerators of those with cancer, these databases become smaller, and there's selection that goes into it and some biases that are built into some of these databases. So as we go through and get better numbers, I think we'll have a better understanding of really where we're going. So I think we really seek larger data sets, which will be forthcoming, and we look forward to being able to present that data to better define how this disease afflicts our cancer patients. I'm going to turn it over to Laura. We actually asked Dr. Fauci to be on tonight, and he said that he'd be happy to do that, but he said that Laura was more qualified to talk about testing than he was.
That's exactly what happened.
We said that's absolutely the case, and we're happy to have her take over from here on talking about testing, which is a very dynamic area, as we've seen changes even at the FDA in the last couple of days.
So
yeah,
really quick before we, one second, before we go on to the testing part with Dr. Musselwhite, I would just like to ask the panel a little bit about some of the data. So Dr. Monk, if you could give us some comments on, the data that Dr. Herzog presented, and, if you feel that there are any particular factors in patients that you see with ovarian cancer that may put them at greater risk. Is there certain therapies? Is it just the cancer? Obviously, there's no data, but what are your perceptions there?
Yeah, I'm not really sure what I'm supposed to be afraid of. So you say at risk of what? Getting the virus, getting symptomatic, because not everyone that has the virus is symptomatic, being admitted to the hospital, getting intubated, or dying. I get it. You don't die of the virus unless you get it. 80% of the deaths in Arizona are from nursing home members, 80%. So for the general public, and overall, the death rate is about 3%. So of that 3% that are infected, again, 80% are from nursing homes. So there's no question that we're trying to be smart. I don't mean to minimize it. This is serious. Dr. Brown said that. But I think that as I always say, every patient I see is affected. I've never met a patient that's infected. So I'm trying to deal with the new norm. So that's kind of some of my general thoughts.
Thank you. And Dr. Brown, do you have any comments?
Sure. I think our big thrust at Levine has been prevention. And we've been so very careful to try and avoid risk in our cancer population, really thinking ahead, trying to establish whether it's social distancing, tiered teams, because specifically for our patients with ovarian cancer, one of the things is our folks tend to be older, right? So, the people who, as you learned from Tom, are the most at risk, they tend to be older, and so are our ovarian cancer patients. So I think that puts our patients at risk, even without comorbidities. Plus, a lot of our ovarian cancer patients do have comorbidities. So just by definition, they do tend to be sicker and therefore at higher risk. And that doesn't even take into account neutropenia and lymphopenia, which may be additional risk factors. So those are the things that I tend to think of as we sort of try and manage this situation, giving recommendations to our individual ovarian cancer patients and making sort of system-wide recommendations. Right?
Great, thank you for that. And so now we will turn it over to Dr. Musselwhite for testing.
Thank you. This has been a very hot topic for everybody. Not only what is it and how do we use it, but how do we get access to it? To start off, I'll reiterate Dr. Brown's point that we have more cases now here in the United States than anywhere else in the world, over 1.2 million. And these are, by the way, confirmed cases. So these are patients who were tested and who had a positive result. So you can extrapolate and think we are missing quite a few that never got to that point or who had a false negative because testing isn't perfect. This is cases per 100,000 people by country. And as you can see, the United States has recently taken over Italy. It is in third. If you kind of want to make it a contest to the bottom. And then deaths per 100,000, our death rate is a bit lower, but again, these are just among people who are confirmed and tested. So I would suspect it could be a little bit higher among those who are symptomatic. Again, when we start expanding testing of asymptomatic patients, this number will probably drop. So COVID-19, why did we worry about it, and why have the epidemiologists been warning us about this for a couple of months? It is a very, very respectable virus. Mortality rate overall is probably going to be 1% or a little bit less, as I mentioned, when we expand testing to those who are asymptomatic and probably never will develop symptoms. We know that asymptomatic transmission occurs, and there was a study that came out in Singapore a couple of weeks ago highlighting that about 6% of their new cases were attributed to transmission from an asymptomatic carrier. The virus also has a pretty long incubation time. So the median period is about 5 days, meaning that time from infection to becoming symptomatic is about 5 and can go out to about 12 days for most people. What that means is that almost everybody who will develop symptoms will get them within 2 weeks. The R0 or R0, the other name for that is reproductive ratio. And you guys have probably read a lot about this in the news lately. It means that for every person infected, they will go on to infect 2.5 to 3 people. That number changes a little bit and can change based on population density. So if you think about New York City, their R0 is probably higher than this. If you plug this into an equation, most of us do think that about 60 to 70% of the population will have to be exposed to develop some level of herd immunity to stop active transmission. That means either getting infected or getting a vaccine. Certainly transmission is continuing. We're seeing increases in the Southern Hemisphere. We are worried that that is consistent with a large and second wave that will probably hit around flu season, September, October, something like that. And it's important to know that this coronavirus is novel in humans. No one we know has ever been exposed to it before, and there's very little reason to think that we have cross immunity from some of the other coronaviruses that cause seasonal colds, for example. Taking all of these things together, it makes it a very transmissible, portable virus. Another question that has come up quite a bit is if a patient has a positive result or a positive RT-PCR test, how long will they stay positive? And we've shown that, again, this virus is very respectable. It's prolonged. And if you look at these charts on the left-hand corner here, each of these lines represents an individual patient. And overall, the message is that it varies, but can extend from 14 days to past 28 days of detectable virus in a patient from time of symptom onset. If you look on the right, in the same Nature paper, they showed that nasopharyngeal swabs tend to detect higher viral loads, which gives us our reason for why we use nasopharyngeal swabs to kind of establish our gold standard of testing. It just detects virus better than other methods. The next question that these same researchers ask themselves, and that I think we all have, is, okay, a patient is still shedding virus. Does that mean they can actually transmit the infection to somebody else? So as a way to answer that, they took the virus from those same patients at various days from symptom onset and tried to culture it. And the idea is that if a virus can replicate, it probably is transmissible. So you can see that the ability for the virus to replicate was about half that of the viral shedding, which implies that, even if they're shedding virus, they may not necessarily be able to transmit it, which is kind of a glass half full slide among all of these, probably. As far as testing itself, there are 2 kinds. One is viral testing. I think the one that we have been talking about the most, and that testing is basically, am I infected? Can I transmit it to somebody else right now in this moment in time? The second test is antibody testing. And the only question it can really answer for us right now is, have I been infected? This is the current list of Centers for Disease Control priorities for RT-PCR antigen-based testing. So am I currently infected and can I infect others? High priority patients are the pretty obvious ones that I'm hopeful most of our viewers can access at this point. Someone in the hospital with symptoms, high-risk individuals with symptoms. The key is with symptoms. Priority people, one tier down, include those who have symptoms but may be less risky. They've added to the number of symptoms this includes. And in our world, we're actually more liberal than this. For our cancer patients, we really will test anybody for almost any reason. And I'll get into that a bit later. And then at the bottom, they even add several groups of patients that have no symptoms, and that would include congregated living facility patients. And that makes sense because I think we heard earlier 80% of infections in Arizona, for example, are from patients in these areas. In North Carolina, it's a little bit lower, but certainly a very high incidence and probably our highest risk population are our canaries in the coal mine, if you want to think of them that way. This is ASCO's current guidance on diagnostic testing for cancer patients. First, the CDC has no cancer-specific guidance, and then from ASCO's website, I took this evening to make sure I had it most up-to-date information. First, as they say, refer to the CDC. So, of course, there's no particular guidance other than if they're symptomatic, test them. And then at the quotation in the bottom, they suggested it would be reasonable to test asymptomatic patients who we will be exposing to things like immunosuppressive therapies and who would be otherwise at risk for serious complications. And I would argue that's any patient that has cancer. The data that we're looking at as far as morbidity and mortality is pretty impressive. And I think we could probably lump anybody with active cancer in that category. So now that we've acknowledged there's not a national stance on who do we test and how do we test, I thought I'd tell you a little bit about what we're doing at LCI. And the big caveat here is it is institutional specific, and it all depends on your own testing capabilities. So for us, we came together and decided that anybody we would be seeing in clinic who is coming from a congregated living facility, that includes a jail, a prison, a nursing home, a rehabilitation facility, a homeless shelter, anyone getting a procedure, whether aerosolizing or a major surgery that would put them at high risk for mortality, any cancer patient getting any kind of treatment, and then certain healthcare workers working with immunosuppressed patients, for example, our bone marrow transplant team. And then new stroke has recently been added. To give you an example of why we care so much about those coming from facilities, these are some North Carolina numbers I took from about 2 weeks ago. And you can see we aren't at 80%, but we were at 17%. And that number has probably gone up quite a bit. And in looking at the North Carolina data this evening, we have outbreaks now at 60 reported nursing facilities throughout the state, 4 jails and prisons, and multiple other rehabilitation centers and homeless shelters. I think one thing that really limits operationalization, if that's a word, of testing is how do we test for viral RNA? It's tricky. I've shown you that nasopharyngeal swabbing is kind of our gold standard modality right now. An upper respiratory sample is needed. Right now, that means most need to be collected by a healthcare professional, and it is an aerosolizing procedure. So you have to don full PPE when you're doing it. There are a couple of self-collected methods that have just been approved and added by the CDC. One is a nasal mid-turbinate swab, and one is an anterior nasal swab. One of them, they have to be on site and you have to watch them do it and make sure they did it correctly. And then the other one, there is home collection possible, but again, the sensitivity and the specificity go down with those. I mentioned for collecting most samples, you need full PPE. What does that mean exactly? It means a gown, a gloves, eye protection, N95. You can imagine these are critical resources for all of us. And I would argue there's no healthcare system in the country that has enough PPE right now, nor will they in the foreseeable future. So how do we test these patients without burning through everything at a really quick rate? As far as those handling of specimens, there are a lot fewer requirements there. You just have to wear a regular mask, wear some gloves, and then limitations that we've all read about. The viral transport media is only made at a few places in the world, and there is a severe shortage of the media, but also testing kits. And then once we do have testing kits available, there's been a lot of issue with actually distributing it to where they're needed. And that's happening at the local, state, and national level. There's also quite a few delays in result reporting. For example, we have some smaller rural areas in North Carolina, of course. They're sending their tests to the health department, and turnaround can often be 5 to 7 days. So you can imagine that's delaying care for the patient and delaying contact tracing, and certainly not the ideal scenario during an epidemic. I did want to take some time to talk about serologic testing because I know it's been on everybody's minds, and it really is going to be a very, very important thing that we do in thinking about reentry for the country. It's important to acknowledge that we don't know much about an antibody response in infected patients. We don't know what the utility of a measured antibody is for this virus. Some potential uses might be detecting false negatives that are negative by PCR, especially patients that have really low viral loads below the detection limit. It could be very useful for identifying good convalescent plasma donors. For example, do they have a certain titer of antibody? It can certainly help us with disease prevalence, so how many of us have truly been exposed, and then verify whether a vaccine response is elicited and whether that antibody production to that vaccine actually correlates with protection from infection. If we don't validate it correctly, there are some major challenges to using and interpreting this test. We can have false negative risks, especially if someone has mild disease and low titers of antibodies. We can have false positives, which we already see, particularly with IgM, and there certainly can be some cross-reactivity with some other common cold coronaviruses that I showed here. Right now, there are multiple that exist. The performance is pretty variable. There are a couple of different targets. Again, even if we detect the antibodies, we don't necessarily know if they're protective or if they're sustained for a period of time. I think a good example to remind ourselves of basic immunology is to think about hepatitis B. All the antibodies that we measure don't necessarily confer immunity. There are a couple of pretty cool, innovative projects happening. One is from this foundation called FIND, which is conducting independent validation of these different assays to find a good one. And then once they find a good one, procuring it and actually implementing it. And to give you an example of how an antibody can give us some false reassurance, there are a couple of FDA authorized tests that have 96 to 98% specificity. But that means that in a population with low prevalence, which I think we probably are here in Charlotte, if our prevalence is 5% or less, a positive result is more likely to be a false positive than a true positive. So you can see there are a lot of nuances even to just a basic yes or no lab result. Additional problems, there's no universal standard for reporting it. The test detection limits are different. Currently available assays, some of them are just qualitative. They're not quantitative, so they don't actually give us a good idea of whether you have a lot of neutralizing antibodies that might be helpful to treat somebody that has COVID, for example. And then for right now, I think I mentioned this, the most useful role for antibody testing is as a surveillance tool to look at population exposure and prevalence. one last thing to think about, and I think this is probably true of the entire pandemic, is we really don't know what we don't know. And we have to know that we don't know that we don't know, if that makes sense. Detection of IgG will probably confer some protection for most people. We don't have evidence that this happens, but it has been true of other coronaviruses, including SARS-1. Most people were immune, or at least had a level of immunity for a couple of years after exposure. For most of them, that waned within 4 years. We also need to understand which antibodies are truly neutralizing and protective. And then another thing that we don't like to think about or talk about as much is, does antibody production with this virus lead to immune enhancement? We have shown that to happen with a couple of other viruses, including dengue. For example, there were a couple of vaccine candidates in trials that actually caused cytokine release syndrome and made subsequent infection worse than if they hadn't been vaccinated. So there is a real concern that that could happen. I think it's less likely, but it's possible, and we don't know what we don't know. Just to summarize a bit, viral testing is limited, both by our supply and how we distribute it geographically. Right now, serologic testing with an antibody test is really limited to surveillance, and the IgG here probably is much more important than an IgM test. We don't know if it confers immunity. Unfortunately, new infections and new deaths are going to continue until we have that level of herd immunity, where up to 60 to 70% of us need to be exposed either to the virus itself or to an effective vaccine. Asymptomatic testing in our cancer patients will be important. We know they have very high morbidity and very high mortality across the board. There are no national guidelines, and what we do right now is mostly based on what's available at the institutional level. Most of that will be shaped by our supply and what the logistics of testing are. Acknowledging it's an aerosolizing procedure, you need a lot of PPE to be able to do it, and a lot of manpower to operationalize it. And that's all I have.
Thank you, Dr. Musselwhite. So now I'm just going to open it up to our panel to kind of talk on some of the top the points that you had talked about. So Dr. Herzog, I know when you were speaking about the cancer patients, you had mentioned about testing. So, what has been your experience with this?
Yes, so in Cincinnati, what we're doing is we're testing everybody who's having a procedure. So everyone who is undergoing a major surgery or any surgery, frankly, and then any of the aerosolizing GI scopes and all that, they're all getting tested. They have to be tested 2 days before because of our turnaround time and administration of getting it. I'd like to see it the day before. We have been testing anyone with symptoms, obviously, that has cancer. We're probably moving into testing now for administering cytotoxics and other anti-cancer therapies. If they're obviously for bone marrow transplant, all those types of immunosuppressing type of regimens, they're getting tested as well. So that's what's going on. I told you about my personal experience. I was in Wuhan, and then I had a cough in January, so I thought for sure I had it. I went and got one of the probable knockoff IgG, IgM antibodies. It said I was negative, and I was very hopeful I'd be positive. I was happy to go to the ICU and help out at that point, but unfortunately I was not.
So Tom, this is Brad. You're right. Testing is really within the short term widely available. We have a testing station at our hospital, and we're doing the same testing before every single procedure. Why don't we just test every patient prior to every cycle of chemotherapy? I mean, most of our cytotoxics are every 3 weeks. And if we can test every surgical patient, we're talking about this in our practice. Yeah. Just, the travel, patients don't want to travel, but why don't they just do it? Yeah, go ahead.
Great point. In Ohio, we've just gotten there in terms of capacity, probably in the last week and a half or so. So up till then, we really weren't there. So I think it's still going through the administrative bubble up until we actually make that change. But it makes sense.
Laura, what do you think? Yeah, go ahead.
Yeah, I was going to say, you mentioned, the capacity of testing. And I think that's a really big point that, we have been very careful, I think, across the country in every center, not to burn through all of the test kits available. And I think Laura can probably speak to that. What do you think in terms of even prevalence? How does prevalence impact how we test?
Oh gosh, that's a tough question. I think the big picture for any epidemic is the perfect is the enemy of the good and cannot lead to decision paralysis. So sometimes you just have to do what you can do. For us at LCI, thank goodness in the last week, we have decided to test everybody prior to every cycle of chemo. I think the rationale is good, and part of that hinges on why we're doing it. So the reason we're doing it is patient safety, but also staff safety. If you look at the reason why they're doing it from a procedural standpoint, part of it is there was a paper that came out that showed pretty high mortality. I think it was 40%, and those with active infections undergoing a major surgery. But part of it is also the aerosolizing procedure risk to staff. And if you believe that result, that's a whole nother problem. If you believe that testing result, it could inform how much PPE you think you need to use for that particular procedure. So prevalence does matter, but I think at this point, we don't know. We don't really know what prevalence is. We're not testing asymptomatic carriers who, again, can transmit virus. So right now we have to take a very precautionary stance rather than reactionary, because we just don't know what we don't know.
I've also heard that maybe the checkpoint inhibitors might be a little protective. At least they certainly don't increase the risk. Is that what we're seeing?
I haven't seen that data yet, but I would love to. I hope that's true.
Yeah, I've heard it more as a theoretical, Brad.
Right.
But it makes some sense, right? Because of this where we sort of turn this virus, when it goes through the receptors, the ACE receptors and so forth, seems to turn the immune system onto the person, and the patient, the immune system starts attacking the patient itself. So if you're on an immunosuppressive agent, now I haven't seen that convert to, other agents. So I don't know. It's complicated.
So Tom, that brings up the question of sort of the other side of the coin of what if you cause neutropenia? Should we really be careful with our dosing of patients? And even though with ovarian cancer we often don't end up seeing much immunosuppression, much neutropenia, what do you and Brad think about starting low and dose escalating?
It makes me nervous. I'd like to hear what Brad has to say, but it definitely makes me nervous to have, because even though you say that we don't get that low, if you look at the ANCs on my patients that come in for chemo, it's still pretty close. I mean, there's a number of patients that are on their 4th, 5th cycle of chemo who, carbotaxol even, that their ANCs routinely are just under 1,500, and we even say go ahead and treat. Makes you a little more nervous with the current environment.
Yeah, I think dose intensity does matter at some level. Personally, I'm way more afraid of cancer for my patients than I am the virus. I get it. My prior comment made it sound like I was trying to minimize the virus. We have to do everything we can to stay safe. Absolutely. Okay. But recurrent ovarian cancer is 100% lethal. So I think the best way is to be smart, Jubilee, like you said. I think, as you said, Laura, we have to test better and more often. And then obviously, if there is an oral therapy out there, we have to utilize it. So we have 4 sort of these weekly WebExes. This is sort of an introductory. We didn't talk about ovarian cancer a lot. The second one is going to be more surgically focused. We're going to rely again on Dr. Brown to help us as the president of the Minimally Invasive Surgical Society. The third, we're going to talk about systemic therapy. We're going to give you some clear examples where oral anti-cancer therapy may be the preference, maybe even from a therapeutic standpoint. And then the fourth one will be the future, including vaccines against the virus and how this is impacting clinical trials. So again, surgery, systemic therapy, future, including clinical trials and vaccines. So I'm seeing some questions in the question and answer. Hopefully you'll continue to join us through this series. But we're using more growth factors. So rather than reduce the dose and increase, I just see there are 9 of us here in Phoenix. We talk all the time. And we sort of in every healthcare system do both residencies. You can feel it that in the so you're not supposed to, just what you said, Tom, carboplatin, paclitaxel, there are ASCO guidelines, and if the risk of neutropenic fever is less than 10%, you're not supposed to start growth factors. And even in the elderly patient, that probably is less than 10%, again, neutropenic fever. But I see me and my colleagues, they see a 65-year-old who's going to start carboplatin, paclitaxel, AUC is 6,175 over 3 hours. They just give them, peg filgrastim.
Yeah.
Mm-hmm.
Yeah, and also what line of therapy? You brought it up, Brad. I tend to be more, and always am, but even in this current setting, I tend to be more aggressive with my frontline patients, in spite of the virus, versus those with recurrent disease. Maybe back off a little bit in some ways.
Yeah, that's true. Yep. Mm-hmm.
Thank you. That was great. Thanks, Dr. Monk, for recapping our series too. So we will have a full section on all the treatment regimens and how they're changing. So that should be really interesting. The testing was really interesting today. So just to go through some of these questions. So we do have one, kind of what you were talking about. If you want to take this one, Dr. Monk, how have treatment regimens been adjusted? So it is very broad, very general. So, just anything you can provide for the audience.
Well, there are a number of strategies. Number one, we talked about oral anti-cancer therapies. I'm intrigued about the sort of rapid FDA approval of pembrolizumab from a 200 milligrams every 3 week to a 400 milligram every 6 weeks. And it's for all adult indications. And as you know, in gynecologic cancers, we have 3 pembrolizumab approvals, right? 2 in endometrial cancer and 1 cervical cancer. So immediately, and not just because of the virus, as Tom and I said offline, it just makes sense, but we have converted to an every 6-week regimen. And as you can see from the epidemiologic data that was presented, 6 weeks can be a long time as to what happens in the community relative to the virus. So those are the 3 major implications. Is 1, increased use of supportive care, including pegfilgrastim. 2nd, increase of oral anti-cancer therapies. And 3rd, increasing the cycle length, particularly of the 3 indications for pembrolizumab, from 3 to 6 weeks. That's what I've seen.
Yeah, Brad, how about Dr. Brown? There.
Yeah, I was going to say, Brad, I think you hit the nail on the head. You listed everything that's really key there. The only thing that I would add is the consideration of neoadjuvant chemotherapy in our more elderly patients. We've used that approach increasingly during this time when we see patients who come in with advanced ovarian cancer, giving neoadjuvant chemotherapy so that then we can come in and potentially even do a minimally invasive interval debulking procedure, limit their time in the hospital, limit exposure. And so that's really changed the way that we practice with it.
I always say that the hardest decision, and Tom will show it in our 3rd webinar, the 3 key decision points in the frontline treatment of ovarian cancer. But the hardest decision, I think, is between neoadjuvant and primary debulking. And with primary debulking, you have to be right twice. So you have to be right in that you can get the majority of the tumor out, whatever that means, ideally R0, number 1. But you also have to be able to treat that patient right at about 3 weeks from her operation. So if she gets delayed to a 5 weeks since her operation, you didn't really do her any good. You may have felt good, but when you scan those patients at 5, 6 weeks, no matter what you said in the operative report, there's a whole bunch of tumor there. So I've actually been I think this is an extreme comment, but it's still true. If you see a 75-year-old with ascites, she probably should never be cut open. And I would argue that if you are going to cut her open, you should stick a laparoscope in there and look around for those reasons. And we'll talk about it. That's going to be a fun conversation in the next webinar.
Yeah, and I have a lot to say on this, but in the interest of incentivizing you to watch the next 2 episodes, I'm not going to say anymore.
Great. So we'll go on to the next question. So we are going to also talk about this in the 4th one, but what about some of the clinical trials, specifically starting new ones during this time? So are new ones starting, or are they just currently on hold? What's kind of been going on in the clinical trial field?
So for me, I'm deputy director of the Cancer Center, so I've been intimately involved with a lot of these decisions, and we have a very small committee, not a very popular committee, because we decided which trials we were going to close during this time. So we went after trials that, first of all, we closed all the trials that were non-interventional. Then we closed all the trials that we thought there was a decent standard of care treatment. In other words, we were maybe looking at patient-reported outcomes or equivalence or that type of thing. We really weren't moving the bar very much, so it was unlikely that we were going to increase survival with that study. And then we looked at what we kept open were those trials that where there for sure was very little in the way of options available to them, or the potential for improving survival was significant. And so you can imagine some of the subjectivity that went into that. But we had to draw the line. We suspended a lot of the secondary endpoints if they didn't affect the primary endpoint in terms of blood draws even and getting tissue, some of the translational components. Or if they affected patient safety, of course, we kept them in. And so we'll get into that more in the last webinar. I'll show you some data of what we did specifically, because I think it's interesting. But I think that's been the trend everywhere. I'd like to hear what my colleagues have done at Levine and in Phoenix.
Tom, you and I talk all the time, and I'm going to just even give some more, granularity there. You're still enrolling in Athena. I know you are, because we talked about it, and you have 5 patients who are, just finishing their chemotherapy, and you could say, I don't want to do surveillance. I do want to do surveillance. I don't want to do maintenance. That's not what you just said, and that's a concrete example. Is you say, look, these patients have a 75% chance of recurrence, so I'm going to give them maintenance therapy, which is an IO, a PARP, or both. And so
we kept that trial open. Yep.
I know you did, and that's really a concrete example. Yep. It's interesting. I don't do any of those trials that you closed. So I don't do PRO studies. I don't. Yeah. So I dealt with a patient today for the Iovance TIL study from Alaska. I get it. She has to get on a plane. She's going to die of her cervical cancer. I'm going to enroll a 29-year-old on Monday. I just worked through the documents on the Genmab combination with Pembro and tivozumab vedotin. Again, she's 29 years old and she has recurrent cervical cancer. So that's what I did today. And
those are life and death. Those are all life.
Those are a big deal. Mm-hmm.
Your ovarian cancer recurs, you're in trouble. Your cervical cancer, if you don't get it under control the first time, you'll never will.
Mm-hmm.
Well, Levine, we've had new starts during this time, but we've continued our patients who are actively on clinical trials. So, and we're looking at ramping even new starts up now. Laura, do you want to add?
Yeah, I would say I agree. We shifted our workforce dramatically, and they actually helped with protocols for COVID because we did have the capacity in a way that the health system, that could help the health system. And I think now we're just starting to refocus and open up some new trials in the next month.
Laura, there's a question, should we be tested? I mean, we talked about testing our patients, and, someone said, well, what test? Well, the test that you have available. But maybe I should be tested. Tom, you were tested.
Yeah, and there was another question I saw in the queues: should caregivers be tested.
Yeah.
So maybe you
Right.
can handle both of those.
And there's also questions about symptoms and about fatigue. I'm tired all the time. I mean, I'm sitting here drinking, my Rockstar. So I get it because, Herzog got me out of bed at 6 a.m, for a conference call. And that was 13 hours ago. That's why I'm tired.
Yeah. That's true.
Yeah, those are interesting questions. I think if we're asking them, the answer is usually yes. It's kind of, if you think you need to do an LP, you're asking yourself, should I do an LP? The answer is usually yes, we should. I guess the question is, why are we testing and how frequently would it be helpful? So if you remember the not HIV, I'm converting back to my former life, but the RNA test is a snapshot in time. So if we're going to test an asymptomatic, and first of all, if you're symptomatic, of course you should be tested. If you're a cancer patient with any kind of viral prodrome, and we know that our patients present differently than immunocompetent patients, for example. So someone will tell me I have a runny nose and I feel really tired, and I will get them tested for COVID. But as far as how do we incorporate testing into caregivers, I think we should. I think it's hard to figure out how. There are a couple of point of care tests that are coming through the pipeline that will be useful if they can be validated. Right now, the sensitivity and specificity are pretty low, like think in the 70s, something like that. Although we really don't even know what the gold standard is, to be honest. As far as healthcare workers, we are starting to do that at LCI. I think there are a few reasons to do it. One is not only are we able to transmit active virus to immunocompromised patients, but two, have we been exposed? And once we know if a antibody test actually will show whether there is some immunity, that would be extremely helpful when we're figuring out who works with high-risk patients and who doesn't. So we're piloting that actually next week at LCI, where we will be testing all Levine Cancer Institute employees who want to be tested for the antibody test, and then eventually we'll also do the RT-PCR. I think it'll be really interesting, and we do have a couple of running bets on what the prevalence will be among the healthcare workers.
Thank you so much.
Yeah. Well, Laura, when are we going to have an antibody test that you believe in, that you can say, if this is negative, the probability is quite high? Where are we with that? Because it seems like, based on the prevalence and everything else, we're still not quite there.
No, we're not. And, and to give credit where credit's due, science has propelled itself at probably the fastest rate we've ever seen. I mean, we may have a decent vaccine in advanced clinical trials by this summer, an mRNA-based vaccine, if you believe it, which we've never had before, by the way. The question of when will an assay be validated, and when will we use it and say, yes, we believe this result? I think we're at least a few months away from that, and I'm an optimist. But hopefully soon. Once we validate an antibody-based test, the validation first is really, it doesn't mean this person has been exposed. It doesn't mean, is this person immune or have some level of immunity? That's a whole separate validation technique, and that will need, more prospective work over time. For example, is someone reinfected? That takes time to get those data points.
Right. Thank you.
Wonderful. Thank you. Well, that appears to be our time for tonight. So we'll wrap up this discussion. I want to give a huge thank you to our faculty tonight for taking the time out of your schedules to do this discussion with us. Thank you to our listeners. And I truly hope that you were able to gain valuable insight into how cancer treatment is changing during this time. So you will be able to go back and listen to this webinar. It will be posted, and you will receive a link to watch the webinar again shortly following this. So continue to visit OncLive.com, sign up for our e-newsletters, or follow us on social media, on Twitter, LinkedIn, and Facebook to get updates on when we will be broadcasting more of these. We will have our panel back, Drs. Herzog, Monk, and Brown next week to speak on some of the surgical approaches. So tune in for that. Should be a wonderful discussion and a lively one. Again, so thank you. And that concludes our webcast for tonight.